Usually when we talk about a medical diagnosis, there's this expectation of precision, like engineering almost.
Right.
You break your arms, the x-ray shows that jagged white line, and the doctor just points at it and says, there it is.
Yeah, it's binary. The bone is either broken or it is not broken.
And it's comforting. We like things to be visible, right? To be easily categorized. But then you step into the world of female pelvic health and menopause, and suddenly that x-ray machine is it's useless.
Oh, completely.
We are looking at a diagnostic landscape that is entirely murky. So today, for you, the learner, we're taking a massive stack of medical literature on a deep dive to uncover why female urinary incontinence isn't just a quote-unquote weak muscle problem.
Right.
It's actually this microscopic story of tissue, collagen, and hormones.
It is the absolute definition of diagnostic muddy waters. And the stakes, I mean, they are incredibly high for the quality of life of the person experiencing it.
Yeah.
The misconception is just so deeply ingrained that people assume the only way to treat a leak is to build a stronger muscle.
Right. You get older, things get weak, and you just need to do endless Kegel exercises at stoplights until you're fixed.
Exactly.
But looking at the clinical data here, we aren't just talking about muscles, are we? Okay, let's unpack this.
Not at all. If we look at how the body actually develops, the bladder, the urethra, and the vagina all share a very specific embryonic origin.
Okay.
When the body is first forming in the womb, these tissues develop right next to each other from the exact same primary structures.
Oh, well.
Because of that shared history, tissues like the urethra, the vagina, and a specific triangular region at the base of the bladder called the trigone, they are all heavily packed with estrogen receptors.
So they're completely intertwined from day one.
Exactly. And those receptors, specifically alpha and beta estrogen receptors, they act as tiny cellular docking stations.
Just waiting for the estrogen.
Right. They're sitting there waiting for estrogen molecules to bind to them and tell the tissue to stay plump, elastic, and healthy. So when we talk about treating the urethra, we cannot ignore the vagina and vice versa. They're part of the same hormonal ecosystem.
Okay, so to understand how to fix the plumbing, we have to understand how the plumbing actually prevents leaks when it's functioning optimally.
Yeah.
Because it's clearly not just a simple mechanical shut-off valve,
The medical term for this everyday mechanism is urethral mucosal coaptation.
Urethral mucosal coaptation, okay.
Right. It refers to the soft internal seal created inside the urethra. Imagine the urethra not just as a hollow pipe, but as a dynamic layered structure.
Okay, I'm picturing it.
For you to remain continent, something called the maximal urethral closure pressure, or MUCP, has to exceed the pressure inside your bladder at all times. Well, except when you are intentionally voiding, of course.
Meaning, like, if the bladder is pushing down with a force of 10, the urethra has to be pushing back with a force of at least 11.
Precisely. And that closure pressure is produced by 4 distinct functional layers of the urethra pressing together.
4 layers. Got it.
First, you have the epithelium, which is the innermost lining. Second is the connective tissue, which relies heavily on collagen for its structure.
Right, collagen.
Third is a vascular layer, so a dense network of blood vessels that acts like a spongy cushion. And finally, the muscle layer on the outside.
See, when we say muscle, I think people immediately picture the voluntary muscles they can flex, like the bicep or the pelvic floor muscles engaged during a Kegel.
That is the common assumption, yeah, but it leaves out a crucial component.
Okay.
The muscle layer of the urethra actually has 2 parts. You have striated muscle, which is voluntary and handles sudden physical stress like coughing or sneezing.
Right.
And then you have smooth muscle, which is involuntary.
Oh, interesting.
The clinical research shows that the maximal urethral closure pressure during rest, just normal bladder filling, is determined almost entirely by the smooth muscle activity in the mid-urethra, not the striated muscle.
Wait, really?
Yeah, the smooth muscle is what provides the continuous resting tone.
So it's not a tight clamp you have to consciously squeeze to hold it in. It's more like the weather stripping around a door.
Oh, I like that, yeah.
Like, even if the heavy wooden door your pelvic floor muscles is closed, if the squishy, spongy weather stripping lining the inside of the door frame is dried out or flattened or just missing the cold air, or in this case, urine is going to leak right through the gaps.
That is exactly it. That spongy weather stripping is your urethral mucosa and that vascular cushion.
Okay.
When those layers are thick and healthy, they press together and create a watertight seal. Studies show that almost 40% of patients with stress urinary incontinence actually have a low maximal urethral closure pressure.
40%.
Yeah, their baseline resting pressure is compromised. The physical stress pressure, the heavy door itself slamming shut when you sneeze, like in your analogies, it's only one part of the equation.
So if this weather stripping seal is so crucial for keeping us dry, what happens during menopause to make it suddenly fail? Like, why does it dry out?
It basically comes down to cellular starvation.
Starvation.
Remember those estrogen docking stations we talked about?
Hmm.
Both alpha and beta receptors are found throughout this entire lower urinary tract. Estrogen is the primary fuel that keeps this entire region robust and structurally sound.
And then menopause hits, systemic estrogen production drops, and the fuel supply is just cut off.
Exactly. When that systemic estrogen drops, it triggers a cascade of physical changes known clinically as the genitourinary syndrome of menopause, or GSM.
GSM, right?
The tissues literally begin to atrophy. They lose their turgor, their cellular plumpness, their elasticity, and their blood supply.
I read in our notes that collagen breaks down during this process too. How significant is that loss, really?
Oh, it is massive. Collagen is the most abundant structural protein in this tissue.
Okay.
In a healthy urethra, collagen fibrils actually occupy twice the volume of muscle.
Twice the volume. Wow.
Yeah, it provides the core scaffolding.
Mm.
The sources describe a healthy, well-estrogenized urethra as feeling stiff, like a piece of uncooked penne pasta.
Penne pasta. That's quite the image.
It is, but it holds its tubular shape perfectly against surrounding pressures.
So when you lose that collagen, the structural scaffolding just gives way, and that uncooked penne pasta essentially turns into a wet noodle under pressure.
Yes, it buckles or collapses under intra-abdominal pressure.
Okay.
It can no longer maintain that perfect watertight mucosal coaptation.
You know, I've always been told that incontinence in older women is just like gravity and general aging, muscles naturally giving out over time. Are you saying this is actually a specific hormonal starvation rather than just wear and tear?
Well, what's fascinating here is that you are touching on the exact paradigm shift these clinical guides are highlighting.
Okay.
Yes, general aging plays a role, sure, but the tissue changes associated with GSM actively compromise the structural integrity of the urethra in a highly specific way.
It's not just getting old.
Right, it is a fundamental change in tissue architecture. The lower portion of the urethra becomes hard and inelastic. Furthermore, the smooth muscle in the urethra actually experiences a decrease in alpha receptor sensitivity.
Meaning what exactly?
Meaning it doesn't respond as well to the nerve signals telling it to stay toned. This leads to urgency and overactive bladder symptoms.
And it's not just the structural architecture that degrades. The actual chemical environment inside the vagina flips completely upside down, right?
It does. The loss of estrogen completely alters the vaginal microbiome.
How so?
Well, to understand why, we have to look at the mechanism. In a healthy premenopausal state, estrogen causes the vaginal lining to thicken and produce glycogen.
Okay.
Healthy lactobacilli bacteria feed on that glycogen and produce lactic acid as a byproduct.
Which makes it acidic.
Exactly. This keeps the vaginal pH highly acidic, usually between 3.5 and 4.5. This acidic environment acts as a shield, keeping harmful pathogens out.
But without estrogen, the vaginal lining thins out, the glycogen production stops, and the lactobacilli just starve.
Which causes the vaginal pH to rise to an alkaline state anywhere from 6 to 8.
And that alkaline environment basically throws out the welcome mat for bad bacteria, right?
It invites harmful gut bacteria like E. coli to colonize the area, leading to frequent, recurrent urinary tract infections.
Oh, the worst.
And these infections further agitate the already thinned, sensitive mucosal lining of the urethra and bladder. It becomes this vicious cycle of structural weakness and bacterial irritation.
So the root cause of this specific type of leakage and urgency is localized hormonal starvation.
Yes.
The penne pasta has gone soft, the weather stripping is dried out, and the pH is out of whack. So the logical question for you, the listener, is how do we feed that specific tissue the estrogen it's starving for without flooding the entire body with hormones?
That is the critical clinical question. Historically, systemic hormone therapy, often called EPT, estrogen progestin therapy, was used to treat menopausal symptoms across the board.
Right, like pills or patches.
Exactly. EPT involves taking hormones orally or through a patch to raise hormone levels throughout the entire bloodstream.
But the sources note that EPT isn't always the best tool for this specific pelvic issue.
No, it's not. The clinical data shows that the systemic progestogens used in EPT can actually increase overactive bladder symptoms in some women.
Wait, increase them. Yeah.
Yes. Progestogens can have an opposing effect on the smooth muscle, sometimes altering receptor activity in a way that causes the bladder muscle to become hyperactive or to spasm.
Oh, that's not what you want.
Not at all. Plus, many patients have concerns about the systemic risks associated with whole-body hormone therapy, such as breast cancer or thromboembolic disease.
Right. You want the structural fix without the systemic footprint.
And that is where local vaginal estrogen comes in as the therapeutic standard for these specific genitourinary symptoms.
Okay.
This is delivered via creams, small vaginal rings, or vaginal tablets. It provides a very low, localized dose of estrogen directly to the tissue with minimal systemic absorption.
Let's get into the mechanics of how this local therapy physically enhances the urethral mucosa. Like what actually happens to the cells when they finally get that estrogen back?
The biological reversal is remarkable. When the estrogen binds to those receptors we talked about, it stimulates cellular proliferation.
Meaning they grow back.
Exactly.
Right.
The epithelium, that inner lining, physically thickens. The estrogen also signals fibroblasts in the tissue to produce more collagen,
Rebuilding that structural scaffolding.
rebuilding it and bringing back that penne pasta stiffness. Furthermore, it increases local blood flow, which restores the vascular cushion, plumping up that weather-stripping seal from the inside out.
And it fixes the chemical environment simultaneously, I imagine.
Because the vaginal lining is thickening again, yes, glycogen production resumes. The lactobacilli return. They feed on the glycogen and produce lactic acid, which lowers the pH back to a healthy acidic 3.5 to 4.5.
Just naturally stopping the cycle.
Exactly. This naturally stops the cycle of recurrent UTIs without relying on constant antibiotics.
Here's where it gets really interesting, looking at the clinical application tips in our sources.
Yeah.
The physical anatomy of how this is treated is actually a great example of the body's interconnectedness. The urethra sits directly at the 12 o'clock position of the vaginal opening. So when a patient uses a topical estrogen cream, they are advised to apply it along that entire 12 o'clock length inside the vagina.
Right, and due to the extreme proximity and the shared vascular network between the two structures, the estrogen essentially diffuses right through the vaginal wall into the neighboring periurethral tissue.
That's brilliant.
You are treating the urethra directly through the vaginal lining. Local therapy acts as a targeted mechanical and chemical intervention.
Right.
However, there is a very important caveat emphasized across the clinical literature, and that is that early detection and treatment are paramount.
Why is early intervention so critical if the tissue can regenerate? Like, why not just wait and see?
Because you want to intervene before irreversible functional integrity changes occur.
Irreversible.
Yes, if the tissue starves of estrogen for too long, the severe atrophy can cause permanent architectural changes. We're talking about the actual shortening of the urethra or extreme fibrosis.
Or it gets all scarred.
Exactly. The tissue becomes so scarred and inelastic that estrogen alone cannot fully reverse the damage. Catching the syndrome early prevents that permanent structural collapse.
That is a crucial takeaway for anyone listening who might be ignoring mild symptoms, thinking it's just a normal part of aging. Don't wait until the weather stripping is completely disintegrated.
Definitely not.
But this brings up a really practical question about treatment plans. If local vaginal estrogen goes in, plumps up the mucosa, rebuilds the collagen, and fixes the seal entirely, does that mean we can all just throw out our Kegel exercises?
I'm afraid not.
I knew you were going to say that.
While vaginal estrogen is a vital adjunct and often the missing key, estrogen alone is not a potent cure for all stress urinary incontinence.
Right.
The physical demands on the pelvic floor are just too great. The sources are very clear that pelvic floor muscle training remains essential.
So what does this all mean for the listener who is doing their Kegels religiously every single day, but still experiencing leaks? Like, why isn't the muscle training enough on its own?
Well, if we connect this to the bigger picture, it's about synergy.
Synergy, okay.
Think back to your door frame analogy. Pelvic floor muscle training is like reinforcing the heavy wooden door and tightening its hinges.
Right.
You have fast-twitch muscle fibers in your pelvic floor that contract forcefully to shut the door when you sneeze or cough. And you have slow-twitch fibers that provide sustained support, holding the door steady against the weight of your pelvic organs from below.
So you need that muscular door to be strong.
You absolutely need it to resist sudden intra-abdominal pressure.
But if you have the strongest door hinges in the world and the thickest wooden door, but the soft weather stripping inside the frame is completely rotted away,
air is still going to get through.
Exactly.
Precisely. In the human body, if you aggressively work the striated muscles through physical exercises, but the smooth muscle and mucosal seal inside the urethra are still atrophied and starved of estrogen, you will still experience leaks.
The seal itself is compromised. So doing Kegels without addressing the tissue atrophy is like buying a state-of-the-art security door, but leaving a half-inch gap at the bottom.
Exactly. And conversely, using estrogen to plump up the weather stripping won't keep the cold air out if the door itself is falling off the hinges because your pelvic floor is profoundly weak.
Right. You need both mechanisms working together.
The ideal comprehensive treatment combines the restored mucosal seal achieved via local estrogen with a strong supportive muscular hammock achieved via pelvic floor training.
The synergy of mucosa and muscle.
It is the synergy of mucosa and muscle that creates true, reliable continence. You are addressing the microscopic structural seal from the inside and the macroscopic muscular support from the outside.
You know, understanding the synergy is incredibly empowering. I feel like it takes the blame away from the person who thinks, I must just not be doing my exercises right, or I'm not trying hard enough.
Absolutely.
No, you might be doing them perfectly, but you are missing a microscopic piece of the puzzle that only local hormones can fix.
It removes the stigma and replaces it with biology. We are looking at a multifaceted anatomical system that requires a multifaceted therapeutic approach.
Okay, let's recap the journey we've just been on to really solidify this for you. We started by breaking the myth that continence is just a muscle flexing, right? We learned it relies heavily on a delicate weather-stripping seal made of mucosa, collagen, and a vascular cushion.
Right.
We saw how, during menopause, the sudden drop in estrogen starves this tissue. It causes the urethra to lose its structural penne pasta stiffness, buckle under pressure, and invite harmful bacteria as the vaginal pH balance fails.
Yes, the GSM cascade.
And then we explored how targeted local application of vaginal estrogen, especially focusing on that 12 o'clock position, diffuses into the tissue to stimulate cell proliferation, rebuild the collagen scaffolding, restore the acidic environment, and plump up that vital seal, all without the systemic risks of whole-body hormone therapy.
A targeted fix for a localized problem.
And finally, we realized that the ultimate fix is a combined effort, estrogen to fix the internal seal, and pelvic floor exercises to strengthen the heavy door.
Perfect summary.
But before we wrap up, we always like to leave you with something extra to chew on. Something that pushes the boundary of what we've just discussed.
Well, there is a detail buried in the research, specifically from a study by Zubina and Smith, that really reframes how we should think about this entire area of the body.
Oh, what did they find?
They were looking at animal models, specifically rats, to trace the nerve pathways in the lower urinary tract. And they found that the sympathetic ganglion neurons, the nerve clusters that project directly into the smooth muscle of the proximal urethra, they actually express both alpha and beta estrogen receptors.
Wait, the sympathetic nervous system? That's our fight-or-flight system.
Yes.
The autonomic network that reacts to stress, anxiety, and heightened emotion.
Almost all the examined sympathetic neurons projecting to the urethra express these estrogen receptors, which means estrogen isn't just acting on the urethral tissue itself, like the collagen or the blood vessels. It is actively influencing the very nerves that excite and control the urethra.
So the hormonal environment is wired right into your nervous system.
Exactly.
So think about what that means for you. If your urethral smooth muscle is spontaneously active and it is wired deeply into your sympathetic nervous system, and all of that is highly sensitive to estrogen levels, how do your daily emotional or physical stress responses interact with this tissue once it is resensitized by estrogen therapy?
It's a huge question.
It really challenges you to view your bladder and your urethra not just as mechanical plumbing, right? Not just as a wooden door and weather stripping, but as a dynamic, deeply integrated extension of your own nervous system.
It highlights just how sensitive our internal architecture is to our broader physical and emotional states. The plumbing is communicating with the brain, and the hormones dictate the language they use.
It is entirely connected. So the next time you think about pelvic health, remember that diagnostic X-ray machine might be broken, and the diagnosis might feel murky, but the microscopic mechanics at play inside the body are nothing short of a masterpiece. Thanks for joining us on this deep dive. We'll see you next time.